Okay, I'd like to introduce today's speaker, John Bain. John is a senior consultant at Stroudwater Associates in Portland, Maine. He has over 15 years of experience in healthcare financial management and consulting. His focus has been on charge master auditing, revenue cycle initiatives, as well as a hospital and physician practice management. John has led initiatives to increase physician and departmental productivity, implement physician-specific and hospital-wide revenue cycle protocols, and develop charge master maintenance policies and procedures. He has had success in growing gross revenue and net reimbursement through combining operational improvements, charge master effectiveness, and efficient business office protocols. Prior to joining Stroudwater, John was an associate director of revenue control and payment systems for Leahy Clinic in Burlington, Massachusetts. And John earned his bachelor's degree from Boston University and his master's in public health administration from Suffolk University. So now I'll turn over to John to share his presentation on best practice business office policies and procedures.
Thank you, Leslie. Just to confirm, too, I'm coming through and you can hear me okay?
Yes, I can.
Terrific. Well, I appreciate it. Thanks, everybody, for joining us this afternoon. And for those of you who have joined us for the previous two webinars, what you'll start to see is a little bit of a theme, and we keep getting back to fundamentals and basics, and finding and talking about things that can have an impact on the financial viability of your organization. And, so the first time we talked a little bit, we talked about ICD-10. Why? Because, people are talking about this fiscal cliff that's coming. The ultimate fiscal cliff really is, October 1st, 2014. So we talked about, a whole body type mentality here about something that was going to touch every aspect of your organization. Last week we focused in on charge master fundamentals. And again, these things touch all these different areas, and you've got to have good levels of communication across your facility in order for you to be effective. Likewise, you've got to have really strong lines of communication to make sure that you guys aren't continually hitting your heads against the wall on items that are entirely and totally preventable. So now we focus in on an area which, in most facilities, it's a very emotional area, right? So, one of the areas that when we talk with and we go on site and we visit with people, one of the areas that is always an area of concern for everybody, and rightfully so, both in a positive standpoint and a negative standpoint, is the business office, okay? So if I'm looking at things from a CEO, a CFO, a C-suite mentality, really there's so much power that resides within the business office that I, at a lot of times, if I'm in the C-suite, are dependent on the information that comes out of the business office, and we hope that it is correct. We have faith that it is correct, that the people within the business office understand what they're supposed to do and are doing the policies and procedures on a consistent basis and are protecting the financial viability of the organization. Now, we all know that there are some organizations that everything that we said right there is absolutely true. The business office is cooking with gas. They've got great leadership. They've got great information. They're doing their job. Now, the question that I always ask CEOs and CFOs is, how do you know? How do you know that the information that's coming out of your business office, that, oh, by the way, you're basing all of your future budgets on, that you're basing all of the departmental information and holding people accountable at the departmental level, is in a lot of cases based on information that's coming out of the business office? How do you know that the information that's coming out of that entity is correct, that it's valid, that it has been vetted, that it is something that you can use and, base the financial viability in future of your organization? Now, a lot of times, we basically, the information that comes back, and, the answer that I get back from the CFOs and the CEOs is, I hope they do. I have trust in her. And then my question back is, how do you verify it? Okay, so one of the things that's critical on this is, because we all know this, business office is a very, when we start talking about it, in good business offices and in business offices that may perform at a subpar level, there's a great deal of emotion that's around it. Whether it's emotion between the departments in the business office, whether it's the coders in the business office, whether it's administration in the business office. Unfortunately, the business office gets, a bum thing a lot of times because they're always the them when we talk to places. They're never really considered the us, okay? So my mentality on this is that every hospital or physician practice, in order to become what you need to be, okay, needs to have the philosophy that the business office is a profit center, not a cost. It is an opportunity to hone and do things well. It is an opportunity to get rid of the us versus the them, okay? And a lot of times, and here's that slide we've seen a couple of times in the previous presentations here, the back end, now for this entire conversation here, let's just consider the back end being the business office. The information that they get, both on a submission standpoint from the department, with an interaction with the charge master, and then the result that they get from the payers, they're the only body within your facility that has the ability to really make sense of all of that. They've got the opportunity to be a QA source. They can ensure that they have steps in there to do redundant quality control. The question that you have to ask yourself, if you are a CFO or you're a CEO or you are part of the C-suite, do we allow our business office the opportunity, do we empower them to provide information back, to take the time they need to make sure that accounts are adjudicated correctly? And if the answer is yes, great. What resources do we provide them? How do we look at them as a them, or do we look at them as an us, okay? So a lot of this starts from the CFO and CEO down, okay? But you also have to, since you guys are responsible for the forest, the trees, and the water and everything, you need to look at it and say, okay, so what is my relationship in my facility or my business or my physician practice between my coders in the business office or my departments in the business office, okay? So as we go through this, okay, everything that we're going to talk about is trying to find ways to leverage the knowledge base to create a situation where you can say that you have ways to verify the information that's coming out. And how do we do that? We do that by working with the business office leadership to create and implement effective policies and procedures which govern their duties day to day. Okay? The most important thing that can happen in a business office is that they adjudicate accounts consistently every day, day in, day out, person to person. Okay? So that you can have faith and trust that the people, if you've got 4 or 5 people in your business office and they're all adjudicating an ED account, they all have the policies and procedures to effectively handle that same account, ask the same questions, get the same results, okay? We want them to be aggressive. We want them to ask questions. A lot of times, facilities will not allow them to ask questions because asking questions slows accounts down. Okay, so it always amazes me that the number of facilities that want to do things fast, but then just don't allow it to be correct. So we're fast wrong, right? And we're not talking about delaying things 10, 15, 20 days, but we're talking about allowing people in your facility the time to get things correct. When we talk about a business office, they have so many things that they have to worry about, okay? It is a complex, mundane job, okay? If you ask them and you give a lot of your business office guys, truth serum, they're going to say they don't really like their job, okay? It's not a fun job. I mean, there's a lot of pressure. There's no thanks that goes along with it. The expectation is to get everything paid, and anything less than that is unsatisfactory. They realize that. They feel that. But the thing is that's not really true, okay? So what we're going to talk about today is, how can we work a little bit around some of these setups that are in our facility and make it so that the business office can be seen as an us, that they can be seen as a value added, that they can be seen as an opportunity and a profit center rather than a cost. Okay, so we're gonna go through a bunch of these different things. So why do we need policies and procedures? Okay, and you have to ask yourself as we're going through, do we have these? Can you if you say, yes, I have policies and procedures for my business office, terrific. Can you get your hands on them? Are they electronic? Are they paper? When was the last time you updated them? Sometimes we'll look at it, and the last time they were updated, APCs didn't even exist. Okay, so we're talking years and years and years ago, and then you look at it and say, things have changed. We need to make sure our policies and procedures change along with the culture, okay? So we need these things just in order to make sure, okay, that accounts are handled appropriately and consistently. So here's my compliance side. Here's how I'm preventing RAC issues. Here's how I'm trying to make sure that all of my gross revenue is appropriate. We got to make sure the policies and procedures allow payer contract terms are followed. We got to make sure that we're mitigating lesser of logic, right? To ask yourself, does your business office even understand what lesser of logic is, right? Appropriate handling of copay, coinsurance, and deductibles, So we've got to make sure that our policies and procedures ensure that the information that leaves on our self-pay invoices is correct. Knowing that most of my patients aren't going to give me the benefit of the doubt. If I screw up, they're never going to pay me, and chances are they'll leave. We know that they judge the value of the care that they receive, unfortunately, based on the validity of the bill that they receive from the business office. Not fair, but more and more people are doing that. As deductibles and everything go up, people are treating hospitals like Walmart. They're making a decision. It's value. It's trying to figure out whether the cost component, are they doing things correctly? And if they can't handle the billing, oh, good God, do I trust the fact of what they're doing clinically, which isn't a fair thing. It just is what it is. We got to make sure that the policies and procedures allow compliance risks to be identified and mitigated on a proactive basis, right? Internal reports, we got to make sure that they're accurate and represent payer intentions. Our policies and procedures allow operating departments to receive accurate, detailed, and consistent feedback from the business office. One of the reasons why a lot of hospitals don't have a denial management program is because the information that comes out of the business office, while the intention is there to provide full data and information, the department gets it and doesn't understand what the question is. So if they don't understand what the question is, either they answer the wrong question, which is bad, or they just ignore it and let things pile up, which then even further perpetuates the us versus them issue, right? It makes sure that from a policy procedure standpoint, it allows our billing and follow-up team members, because they're a team. They got to make sure that they have each other's back, that they adjudicate accounts consistently under approved guidelines. They can't do anything on their own, okay? Everybody has to agree about the parameters around which the business office will facilitate accounts. Now we start getting into the ways that we can verify what they're doing, okay? Many, many, many hospitals don't bother with any of this, okay? They treat the business office as this, almost like they're not even part of the hospital, that they're just a separate entity, which isn't a good thing. They are the most critical component because they're providing real-time feedback. But we treat them and push them back because we don't understand what they do. The policies and procedures allow us to make sure that the business office leadership has a voice in creating an understanding amongst administration, coding, and the departments as to what my role is, okay? How many hospitals, and you can ask yourself this too, at your hospital, if you ask your department whose responsibility is X, Y, or Z, how many times does it come up, oh, that's the business office. I don't care. I don't worry about it. It's not me. Business office. Nope, not me at all. And then you talk to the business office and you say, so what's the problem? Departments won't take any ownership of the things. All I do is fix RAD all day, every day. hey, you got a disconnect here. That's the definition of us versus them. Now, this is entirely preventable. I mean, so this is just a mindset and a decision to go forward and make sure that we get rid of the us versus them, okay? Now, a lot of this stuff, too, this applies equally, I believe, even if you outsource your billing. If you outsource your billing to another agency, it is critical that you get the information from that billing company about their policies and procedures and how they're adjudicating your accounts. Because if you don't agree with some of these things, you need to have a voice and go after them and make sure that they adjudicate your accounts the way that you want them done. At a bare minimum, you need to understand, okay, because you're the one that's going to be dealing with the screaming department or the screaming patient, unfortunately, about how things are handled on the billing side, okay? So where do policies and procedures come from? You know, so, you know, do they just come from midair? Do we just copy them? Do we just call another hospital and say, hey, give me your policy and procedure manual, and I'll just remove your name and I'll put my name on it, and hey, look, I got a manual. Hot diggity, we're good. Not really. Really, we've got to make sure that, you know, we have, similarly to what we talked about from a charge master standpoint and from an ICD-10 standpoint, this is a cross-functional, cross-modality team. You know, so when we start talking about setting and involving, regardless of where you get them, if you're able to get a good set of templates, terrific, okay? You need to involve some people to make sure that those templates now become specific to your culture in your facility or your practice, okay? So at a minimum, you got to make sure that the CFO, the compliance officer, the business office manager, you may have a PFS director, so you may have above the business office manager, you may have somebody who is in a leadership role over your business office that also maybe owns registration and something else. Make sure they're involved. Department heads, not all of them, but you know on your fingers, you know, you can probably count the ones that would be, you know, important to bring in the room, that would be willing to participate. Billing and follow-up team members, don't forget, just even though I've got the business office manager there, you have to look at yourself and say, do I have a strong, knowledgeable business office manager, or do I have somebody who's trying the best they can, but they've been there for 35 years? Do I need access to the billing and follow-up team members to really have a boots on the ground viewpoint, okay? So at a minimum, you got to have them, okay? So you have to ask yourself, if I have a policy and procedure manual currently, who wrote it? When was the last time it was updated? And who was involved in the decision-making process? If it's time to update it, get this team together. And oh, by the way, a lot of these same people are part of your ICD-10 teams, right? So as part of an ICD-10 implementation strategy, you've got to review all of your policies and procedures out of the business office. It's an opportunity, not something that should be looked at as a negative, okay? So not all policies and procedures require the same group. That's fine, you know. So you start prioritizing, you start taking a look at them one by one and try to figure out who should be involved, who should finally approve them, you know, how do they get distributed, you know, all that stuff. From an HR standpoint, if I'm going to hold people accountable, how do I bring these policies and procedures into my HR mentality? You know, I want to hold my business office guys accountable, and I say, okay, so we're implementing policies and procedures. If you don't follow them, then what? Okay? Don't have HR come into this after the fact as a you know, after the what has happened, you know, they don't have to be there to write them, but I think you bring them in as somebody that can be helpful and say, okay, so how do we integrate these into our due diligence and our progressive discipline and all that other stuff, okay? The Revenue Steering Committee, so if you have one for your hospital, which I hope you do, should take the lead in creating the framework. So they should assign probably, a lot of these people are part of your Revenue Steering Committee already. You create that subgroup, and then you report things back to the Revenue Steering Committee or the C-suite, CEO, CFO, as our progress moves forward, okay? So who does what? Okay, so now we should say, oh, great, I got everyone together, okay? Now the hard part is trying to figure out who's supposed to lead, who's supposed to follow, who's supposed to add value, right? So we need to identify it. So CFOs, they should be involved in policies that impact reporting criteria, any customer contact, because we got to make sure that there's consistency in that, contract governance, right? Because the CFO is the one that's going to have to go to battle with Blue Cross and Aetna and United about trying to make sure that they're living up to their sides of the bargain, right? Anything that's related to write-offs and compliance issues, okay? Because CFOs, that's important. They need to know, right? The compliance group, right? So compliance should be involved in policies that impact customer contact and obviously compliance stuff. Now, compliance is a wide range of things. You guys have to decide internally, how do we define compliance? Because it's going to mean different things, right? So some may be, we'll talk about some of these policies and procedures, everything from how I adjudicate an account, or it could be if I'm having the business office be a proactive group on looking at accounts and adjudicating them before they leave and before they hit the scrubbers, So we've got a lot of information that can come from compliance. So you got to make a decision about what it means to your facility, right? The business office and director and the PFS should be involved in all policies and procedures. Okay, they don't get an opportunity to not be participants. The billing and follow-up team likewise should be familiar with all of the policy. So it's incredibly important that they may have input, but they absolutely have to be familiar with all of the policies and procedures that get created. And you've got to take the steps to ensure that that happens. Right? You can't just go through and assume that we created this wonderful policy and procedure, but it was given to everybody and everybody understands it. Create a sign. This is why HR might be great with this. You create the packet, and after they go through and review it, they sign a sheet at the back of it that says that I have read it and I have it in my possession. So that's part of the the due diligence, so that if they start behaving in activities that are contrary to what's documented in my manual, we've got steps to talk with them about things. So they can't say they never knew, right? Some facilities will go and create a test that says that they have to pass the test in order to be proficient in what they're doing. Not a bad idea. Okay, it's not a bad idea to test people. Some people are going to fail. That's okay. But if they fail your test, how are they adjudicating your accounts? Okay, so don't be afraid to step on some people's toes here. And realizing business office, it's emotional. I understand it. Been there, done that. Okay, I run business office. I understand the emotion that's there. But it's critical to make sure that everyone understands what they're supposed to do and how they're supposed to do it. Department heads. Managers, they should be involved with policies and procedures that impact the placement of modifiers, the correct coding initiatives, right? The edits that are related to those. All appeals, the processes, because we always want departments to know what the ultimate, result was of the appeal if they spent time working with the business office and coding to make sure that that gets adjudicated correctly. Administrative write-offs, so that they get through, whether those are timely filing or denials or whatever it is, they really need to understand that, because that's lost revenue to them. Is there a way for them to help, prevent those write-offs in the future? Have them be part of creating those things. Cost of customer contact, hugely important, right? The business office, the departments need to know who in the business office is talking to their patients about the activities that they provided and what message they're giving them. Most importantly, too, denials, on medical necessity, demographic issues, registration, technology not yet proven, so some of our facilities are getting out there. We got new technology, and I'm thinking things are going really well, but all of them are denying. How can I create the policies and procedures in there to ensure that we can get notified on these things so that we can self-correct, that we may need to go and change our budget because of things that they're not going to get paid. Or even, God forbid, these things the payers are getting, and they're flipping them to my patients. Unexpected, but really catastrophic if I didn't notify my patients that may happen, right? So department heads are hugely important when it comes to that. So what's the objective of policies and procedures? Okay? Policies and procedures should create the framework to what? To eliminate process variability. Process variability is hugely expensive. Okay, we know that it's hugely expensive. It ensures customer communication is handled in a consistent and approved manner. Okay, provides employees the confidence in process. You have to ask yourself. Okay, and this is always, it's hard for a lot of times the business office guys to be honest with you about this stuff, but you got to find out from them. How confident are you that you're doing your job right? How confident are you that the results that you're getting are correct? You know, you need to spend time to build that confidence in the process, okay? That's where the policies and procedures kind of come in. They increase departmental accountability and ownership, which is the one thing across the board every business office, if in their heart of hearts, they may not want to relinquish the power, but they do want departments to do their job. You can't make the appropriate amount of money in return out of your business office if the business office is doing departmental work. And part of that is if they're changing modifiers, if they're on their own, they're changing accounts, if they're switching out CPTs, if they're adding HIC picks, if they're doing all of this stuff on their own and the department doesn't know, that is a really, really, really bad thing, okay? So our policies and procedures put the responsibility where it should be. It sets clear expectations. It creates a consistent reporting categories, which is hugely important. I'm not sure, you know, when you look at it and you say, okay, we've got a really good denial management program, but our system doesn't utilize the denial management categories in our billing system. We just don't. We just have everything that goes into administrative write-off. Okay, that doesn't help me, right? I need to know what number in the Department of Radiology from a unit and a dollar standpoint is medical necessity, is pre-authorization. Likewise, I need dollar in unit for lab, right? So if you think about it, if we only look at dollars, right, rad is horrible because they're expensive. If I only look at units, lab goes through the thing because they just generate the most units, right? So we've got to make sure that we create the consistent reporting categories that give us an output that we can use, right? They mitigate compliance concerns. Everything out of the business office has to entirely do with mitigating compliance concerns, right? Because they're the only ones ultimately that get to see all of the combination across the board of all the entities. You know, they're the only ones that see on an ER account that see rad, lab, you know, any types of consults, the ER things, you know, the nursing activity, the physician activity. They get to see everything in one place, right? Same thing if I'm moving accounts together. You know, a lot of hospitals just don't take advantage of the opportunity to do these things and empower the business office to go through and do the job that they're allowed to do, right, that they're there to do. I'll tell you, I've talked with a lot of billing companies. So billing companies that hospitals have decided to outsource their billing operation and give it to this company. Okay, so I talk to that company, okay, and I have the same conversation, and they tell me, well, my billers are too busy to do this. Well, what are they busy doing? So we start pulling the thing back, and what ends up being is that even the billing companies, and this is why it's important, even if you outsource, you got to ask these questions, because if the billing company isn't providing the information back that's useful, what are you really paying for? You know, and then ultimately it comes down to when they say, oh, my guys are too busy, and I ask, busy doing what? Generally, they're busy doing things that aren't their job. They're doing stuff for the hospitals and changing accounts or waiting for things. And you look at the transmissions that come from the billing office to the department, and even I don't even understand what they're asking. And I look at it and say, guys, you're asking if a 59 modifier is appropriate between these two radiological exams. What you sent them doesn't ask that, okay? And what you're saying to the departments is if I say yes, you go away. If I say no, you want me to do something. So if I never want to hear from you guys, them, again, all I have to do is say yes to things, right? So do your policies and procedures, really, if you have them now, are they pushing the departments to answer a question just because they want you to go away, right? Now, anybody that's in administration that's on this call has to understand, the more you do these things, it's going to take longer to get accounts out the door. I'd rather add a day or two to be correct and never see this claim again, rather than do it quickly and then add expense over expense over expense because we've touched this thing 37 times, okay? And ultimately, our goal is to increase gross revenue capture and net reimbursement. Now, the thing is, that is absolutely the same goal of every single participant in your revenue cycle, right? So when you look at it from a coding perspective, a departmental perspective, an administrative perspective, and a business office, you guys all have the same ultimate goal. We want to make sure that we compliantly bill everything that was provided to the patient and that we get paid appropriately. Everyone agrees to that, right? So then when we do that, what's the us versus them? Really, we don't have it. Everyone's going towards the same goal. You have to ask yourself, in your facility, do we live that way? Are we really and honestly going towards that same goal? Ask yourself again, if I'm the CEO or CFO and I'm on this call, what is my goal for the business office? What do I want them to do? Have I ever bothered to even put this on a piece of paper, right? And then look at yourself and say, okay, so maybe I'll ask my business office director, what do you think the expectation is of us to you? And if you're doing things right, the two of you will have the same information on two different pieces of paper. If you're doing things with a different mindset, don't be surprised if either the page is blank or they put something, the business office director says, what you're responsible for? Everything. That's not good, because they're not responsible for everything. So we've got to make sure that the policies and procedures are in place to make sure that we can kind of take the everything out of play and put specifics. So what do? Create the checklist. I mean, and again, this is very similar, and you're going to do this for your ICD-10. So surprise, surprise, why don't you kind of incorporate this into your ICD-10 plan? You get that ICD-10 steering committee that's going to go through and help things. Create that checklist so they make sure that the business office is ready, right? So then you can go through. So policies and procedures. So, when we create a policy and procedure, what should be in every procedure, right? So we want everything to be consistent within a facility, okay? We don't want every policy and procedure to look like it was written by somebody else. And this is why when you start bringing things in from the outside, you start taking the form and contents and fonts and everything from outside areas, and all you're doing is slapping your name on it. But no one bothers to read it because really it's not yours, it's somebody else's, so why do I care, right? So at a minimum, you want to make sure that every policy and procedure should include the following. It should have a specific title. It should have a short executive summary which identifies the issues that the policy was created to address. Okay? So if you can't create that small executive summary, that means you don't clearly understand the problem or what you're aiming for. So that's critical, because you need that group to come together and say, this is what we're trying to address. Okay? And if you can't, then you've got to spend some time getting that piece before you start creating the policy and procedure, right? Makes sense. An effective date and control number. Hugely important, because I want to put this in a book. I want to publish this thing. I want to give this to HR. I want to give this to compliance. I want to have all this stuff there, right? It identifies the personnel impacted by the procedure. Billing team, follow-up, departments, administration, list them. And if you can, there's nothing wrong with putting people's names. You may want to create it at a higher level and make it so that this is can be applied over time, or you can put people's names in there. Now, the good thing about putting people's names in there and job titles is that if people leave or change, it forces you to re-look at the policy and procedure, right? So sometimes when we create the generic ones, they just sit on a shelf. And you may have that one, but you haven't looked at it in 20 years. Okay, you have to pick it up and blow dust off of it. That's not good. Okay, it clearly identifies by signature who approved the final version. So you have to decide who's going to be responsible for the final approval of these things. It's going to be different facility to facility. Okay, I would say it cannot be the business office director by themselves. Okay, because you're asking them to approve stuff for herself. Okay, so it has to be somebody outside in conjunction with the business office to ensure that all policies and procedures for approval of the policy and procedure, that's a tongue twister, are ensure that we've got and we run through all of the checklists, right? So it's important. And again, a lot of facilities won't bother with that. They'll just say, screw it. It's a business office thing. You sign it. You know, it's not what we're aiming for. And the business office really doesn't want that either. They want help with this. You know, it describes in a concise fashion the steps required to achieve desired results. Okay? Now, I'm a fan of bullet points going through. Go through the step. I should be able to look at that policy and procedure, and for the topic that it's addressing, understand how a bill becomes a law. And I don't care if it takes 5 pages, okay? If some of them can take 1, terrific. But you want this in the weeds. You want this so that if you hired somebody brand new and that we've got something that's going to be responsible for how you adjudicate a contractual allowance, that person can read that and end up doing things the way that the same person who'd been there and is doing a great job next to them can do it. You know, so you want these things to be almost a training manual, because this is how you can find out if all of a sudden I've got variability. Go through the steps. Either the steps were wrong or you're not adjudicating those steps appropriately. Okay? It identifies tracking protocols and audit time frames. Hugely important, because anybody that's using the policy and procedure needs to understand that I, as somebody in the facility, may at any point in time come through and audit that process. And this is what we're going to do. And we're going to make a judgment based on what the audit was, whether you're doing your job appropriately. It's important to look backwards. There are going to be people who will continually fail from a business office perspective because they don't follow the policies and procedures, or are off doing it. They're rogue Indians just doing their own thing. We don't want them to do that. We want them to be in a box. It is much more profitable to make sure that they do things the same way every time. They'll identify errors faster. They'll make sure that there are issues that can be addressed to the appropriate personnel. If they don't do that, you've got a compliance issue and you've got an HR issue. Okay? So again, I understand that it's an emotional place, but we've got to make sure that we hold people accountable. What kind of areas need policies and procedures in our business office? And this is just a short list, okay? You're going to spend some time with that team and really try to come up with a whole boatload more on this. But really, at a bare minimum, we've got to make sure that we address these things, okay? Contractual adjustments, bad debt, our administrative write-offs, our denial management activity, okay? Activity within the payer systems. Now, what does that mean? A lot of people, when they're outside of the business office, don't understand the power that your billing and follow-up team has, okay? They have the power to go into Medicare and change an account to make it pay. They have the ability to get rid of what was billed and put something else in that they know will pay, and then send the account through. Problem being is that's fraud. While they may be well-intentioned in doing that, our billing system and Medicare, for instance, are out of balance. So when you go to redrop that bill, you send it, that's not what Medicare paid on. So that when we follow up on things, we're answering a different question. You look at it so that the remit, the dollars are the same, but the codes and everything are not the same as what the billing office has from the billing system. That's a problem, okay? I can't tell you how many hospitals I go into that C-suite doesn't understand that the activity within the payer systems is fully at the whim and the knowledge of the people doing the activity within there, so our billing and follow-up people. And generally, while they don't intend to create issues, they don't intend to commit intentional fraud, if your hospital, if the communication to your billing office is get the bills out, why didn't this pay, get it paid, let's go. It's never, was this right? It's never, are you doing things appropriately? It's, my unbilled is too high, my AR is too high, get this done. They can make it happen whatever way you want. Your wish is my command. Rock on, right? We can't allow that to happen. We've got to make sure that we put constraints on it. And by creating these things, you're also creating the constraints in box for people outside of the business office, which is sometimes almost equally important, okay? Customer contact parameters, hugely important. You know, do you guys have scripts? Do you guys have a consistent format for information that's being dispersed to your patients? I mean, if no, then how do you know what's being said to your patients? You've got to make sure that you've got stuff that governs that. And if people go and provide information that is inappropriate, you absolutely have to have a way to enforce that as a problem. I mean, you have to. If you don't, you're just having, you're just allowing anything to happen under your watch, and that is entirely inappropriate. Self-pay discounts. Do we offer them? Do we, how do we ensure that we're offering them the same to everybody, or is it just friends of the BO? FBO, get the best self-pay discounts. And if you're not an FBO, you don't get a discount, right? Governs the appeals process. How many times do we do it? Is it fully adjudicated? Do we involve the appropriate people? Are we tracking the information? Hugely important. Charge modification within the billing system. Do we involve the departments, or can the billing office just do whatever the heck they want because they know what you intended to do, right? They know that you didn't intend to give this code. It really is this. Why? Because this one pays all the time. We've got to make sure that people aren't doing that. They can't have them go off and just do what they want. They have to work within a parameter. If they are doing that, that's the beginning of the us versus them, right? And we don't want that. The policy components are not likely to be the same for all facilities, so you can't just grab your next-door neighbor's policy and procedure manual. You can't just get it out of the book and just implement it. You've got to make it yours. The parameters must meet the size, scope, services, and abilities of the facility. The abilities is a big one, okay? Because someone's got to look at it and say, does my business office understand what they're doing? And if not, how do I make sure that they do? How do I get them training and education? Likewise, you have to ask yourself, does my facility understand at the departmental level, at the coding level, at the administrative level, do they understand what we're asking the business office to do? Are we setting up a fair framework, or am I setting them up to fail? We look at contractual adjustments, for example, right? So what does the policy govern? So when we start creating these things, again, use these slides as a way to kind of generate these things if you haven't done it. If you do have it, use this type of setup to test whether it's getting bang for the buck. The policy should govern what? Who can adjust accounts manually, right? So a follow-up team member, the team lead, supervisor, or director. Do we have the acceptable dollar values that can be adjusted by each one of those levels? I would say if you've got an account, regardless, that is going to be entirely written off, somebody above the follow-up person really needs to sign off on that. If I've got, in some of the larger facilities, you got, and this is why it's the sliding scale based on the size of your facility. You got to look at it and figure out the dollar value that is important for the people to sign off or, allow other people down the chain to do, okay? The actions that need to be taken when adjustments are 80 to 90%. Set your rate, right? What maybe for your facility, it really has to be 50 to 60%, right? What do we do when there's 100% payment, right? A lot of places will jump up and down going, yay, awesome, look at that, that's terrific. No, that's really bad. I don't want 100% payment on anything. Who needs to be notified about this? Departments, maybe I missed a charge. CFO, my prices are probably too low. State that in. Where does this go? It just can't go to the graveyard of contractuals or payments adjustment. It can't just go and be filed with the EOB. Something has to happen. Appropriate adjustment codes to be utilized within the billing system. Are they payer-specific? If not, ask the question why. If you can create it, create the policy and procedure that ensures that when we get a denial or something or adjustment, whatever it is, that it's payer-specific and that my people are using those routinely and consistently. And that it should address the steps to resolve and address any of the things that we just talked about. Okay? Hugely, hugely important. Bad debt. Same thing, right? So what does bad debt need to do? We need to identify the parameters around the identification of accounts. I can't tell you, sometimes we'll go through and we'll talk with the facilities and say, okay, they say, oh my God, I've got a bad debt problem. Okay, so I said, what does that mean? And they're like, well, I don't really know. All right, so how does an account get to bad debt? I'm not really sure. Okay, so part of the process is it says, all right, who can place the account into bad debt? All of you have people doing this right now. Do you have any policy or procedure that shows who does it on a consistent basis? You know, as your follow-up person doing it, does the team lead do it? Does it go to the supervisor or director level? Okay, bad debt's a really big deal. Okay, so we need to make sure that it's done consistently and appropriately. That it should address the process for accounts, right? So how do I communicate and send things to my outside agency? How do I go and put the appropriate notes at the account level to identify the activity within my billing system, right? So the stuff that's going to the outside agencies and what I'm doing with it, I should be able to tell because there should be a parallel conversation that's happening for activity within my system, right? The notes on accounts within the billing system, right? I mean, so do we use that, the note field, as a commentary, or do we have a policy that specifically addresses how we do it? Do we always use all caps so it always comes across as that we're yelling, or do we have sort of canned text that goes through that so I can have consistency account to account for similar actions, right? The appropriate adjustment codes to be utilized within the billing system. You know, are they payer specific? You know, and again, the steps to resolve and address any of the above. Now, you need to ask yourself, for the contractuals and for bad debt, take a look at your existing policies, okay? Do we do all of these things? Is it clear? The more clear it is in the policy and procedure, the more likely you are to get your staff members to adjudicate the accounts as intended. Okay, if you give people gray area, everyone goes to the gray area because it's really easy to do the gray. Okay, the last bullet point here is really important. Is your policy and procedure created to allow and identify the steps to resolve and address the issues? 9 times out of 10, the resolution of issues aren't included in there. The how is there and the why is there, but not the way to fix the how and the why. So that's really important. And that takes a cross-functional team to be able to come up with those. Administrative write-offs, you know, the biggest bucket that you've got, right? So we can just throw stuff in there all the time. And it's always a huge pot, similar to your contractuals, and I have no idea what's in there, okay? And once it goes in there, that is the elephant graveyard. It just goes in and it stays and it's done, right? So we've got to identify the parameters around identification of eligible accounts for an administrative write-off, the steps to ensure that all options have been exhausted. It just can't be that I'm tired of dealing with it. It can't be that this one's hard. No, put specific stuff in there. It identifies who can write off an account in eligible amounts. And again, be specific. Follow-up person, team lead, supervisor. It should identify the process for our accounts. I want to notify the department that we failed on this. It was a revenue cycle failure from the start, from the first person who talked to the patient to register them to all the way to our follow-up people who couldn't get it paid. We failed because we're writing this off, okay? It is critical that the department know. It should absolutely govern the activity within the billing system, clear notes, clear steps. You know, it should be the dominoes that get followed each time. So if I look at multiple accounts, and this is what I all the time ask my business office clients, give me 10 accounts that went to write-off. I want to see all of the notes. I want you to print the full itemized thing. And then we look to see if there's consistency. The one thing that is consistent, when we look at those things, there isn't any consistency. It depends on the person who did it. It depends on maybe the day of the week, whatever. But they handle things differently every time. That's not efficient at all, okay? We want to make sure that we reconcile for administrative work because these are big deals. If we're having a huge amount of write-offs, and, you know, why we need to make sure we can address that because administration, those are all lost cash. You know, that's a lost opportunity. We got to make sure that we're taking the appropriate actions for that. We got to make sure that the appropriate adjustment codes to be utilized within the billing system are utilized, that they're payer specific. Your billing systems can do a lot of this work. We just have to take the time to set it up and then ensure that our billing staff are using the setup. Okay, and again, steps to resolve. Denial management is a gigantic one, right? So a lot of times we'll go in and say, I have a denial management process. We're really good at this. So I'll ask for the policy and procedure. I don't have one. Okay, terrific. So everybody does everything exactly the same without any guidance whatsoever. No, but they know what they're doing. Okay, how about this? Do you know what they're doing? No, I don't have to. I hope they know what they're doing, and I have faith that they're doing it the same way all the time. Not good. Hope and faith is great to have. We got to make sure that we trust and verify. Hugely important from a denial management standpoint. If done inappropriately, if you've got an us versus them mentality, this is the type of thing that just puts a bigger wedge in between the departments and the billing office because they don't trust the billing office, which is a shame because the billing office is doing everything they can to get these things paid, but it could be that they just don't have the policies and procedures in place. Be payer specific in these things. You know, it should identify the parameters around the identification and trending of accounts. Hugely important. If you don't identify at the account level and trend it, you don't have a denial management program. It needs to be modality specific. RAD versus lab versus PT-OT speech versus VED versus observation. All of these things need to have protocols around how to do it. Okay? You want to make sure that the payer guidelines are consistently followed. Address and identify the use of payer guidelines. Okay? If the options are exhausted, it identifies who can write off an account in the eligible amounts. Again, so we start tying some things into our contractual things, to our administrative write-off things. So we get some consistency across. You need to make sure and decide whether the dollar values need to be the same, or do you want to have a lower threshold here for denial management because we take our denial seriously. Where do the departments come into this? You know, so we need to make sure that the policy and procedure identifies all of that. Okay? Again, the process for the accounts within the billing system. It should clearly identify so my Department of Radiology understands the work that it's going to take to adjudicate a denied account. It's a lot of work. Why don't you take the steps to ensure that everyone outside the billing office understands what we're trying to do? You know, we want to make sure that it eliminates the duplication of efforts. A lot of times in denial management, we end up trying to have a really good process, but I've got the same multiple people doing the same activity on the same account. That's a waste of resources. None of us have staff, you know, more FTEs than we need. I think one thing everyone could agree on is none of us have enough FTEs, right? We got to make sure that we are payer specific and modality specific, and again, make sure you take the steps to resolve and address all of the issues that are identified. One of the areas that's hugely important but is often just relegated to fly by the seat of your pants is the stuff around customer contact, okay? We want to be, you know, when we start talking about when we talk to patients, right, we got to make sure that all of the steps are consistently followed, okay? If I'm making changes around, so customer calls me and says, oh, if you just changed X to Y, okay, it'll pay. Do we allow our guys just to take that stuff and say, okay, well, I want to make sure that the patient's happy. I'm going to go into the payer system and make the change. Because, oh, look at that. If they said, if you just said, if I didn't have a screening colonoscopy, wink, wink, nod, nod, I had a sick colonoscopy because my guys won't pay the screening. If you change the G to a 4 code, that's what they told me. I don't know if that's right or not. But if you did that, it'll pay. So they go in and do it. But is it appropriate? Make sure that any modifications based on customer contact are approved. How do we know? Do they have access to the payer guidelines? Is there a way to judge? Because remember, patients are all of a sudden they're becoming educated, and they're just taking what people tell them in 4 words or less from the payers because it must be correct because they told me that you don't know what you're doing. and the payer's always right, we've got to make sure that our process is consistent and that it identifies what we do when we get intake. You know, what notes do we make that Mrs. Smith called and presented the following, blah, 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 blah. No commentary on whether it's right or it's wrong. It's objective. This is what they said. So that the next time someone gets that call from Mrs. Smith, they say, oh, Mrs. Smith, I see that you called, and this is what we're trying to do. Okay? We got to make sure that we eliminate duplication of efforts, because it can't be Groundhog Day every time she calls about the same account, but just happens to get a different person. Okay? A lot of hospitals that don't have anything around customer contact, which is a shame, because customer contact is a hugely valuable resource for us to make sure that we understand whether we're doing things right or wrong. Okay? When we're within the system, this is one of the sensitive areas, okay? And this is going to take a long time for you to create a really effective policy on, because you're going to have people explain to you outside the business office what you want to do. Now, you know, what they can do, I should say. Now, one of the things that business office doesn't want anyone to know is the power, really, that they have to be able to go and make changes willy-nilly. Okay, not saying that they're doing it, but as soon as you start lifting up the tent and you get under the tent, CFO, CEO, department, coding, all starts going, really? You can do that? That's not good, right? So within the paying system, we have to identify what information can be shared with patients and family members, again, including customer contact as part of the information, right? We got to make sure that HIPAA standards are followed. You know, do we have a listing? Do we train people who answer the phone, you know, and do things within the billing system? Do we train them on HIPAA? You know, we've got to make sure that we provide scripts to our staff that are answering the phones, or provide at least content for communication to patients. Okay? Again, they need to understand payer-specific stuff, modality-specific stuff. This is why we got to pull the departments in. You know, so if I get a call on a screening mammography, who in this facility knows more about screening mammographies than the people who actually provide the test? Okay? So the goal when we start getting into all this stuff, we want to eliminate duplication of efforts. We want to make sure that people are doing things appropriately. Right? How do we govern self-pay discounts? Right? I mean, it identifies clearly, and as approved by the administration and the hospital and the board, the parameters around which discounts can be offered. Again, it identifies that HIPAA standards are followed, that we're treating everybody the same. Again, provide scripts to identify, oh, this is the good news, and we can either go one way or the other. I got a script that says patient happy, here it is. Patient's really not pleased because they really wanted 75%. What do we say rather than, well, you know, well, let me take it to somebody and see if I can fix that for you. I don't want that, okay? And again, each of these steps, when we start getting into these things, all of the policies and procedures should have a lot of the same components, eliminating the duplication, being payer-specific, making sure that the notes are not commentary, that are objective, and that anybody from the outside, when they're reading it, should be able to understand the steps were followed, and that all of the steps were followed consistently and compliantly. You know, the appeals process. Ask yourself, does your department have faith and know that all of the appeals are done correctly, or do they not care because, you know, that's somebody else's job and whatever, right? No, we want to make sure that we've got a policy and procedure that the departments can understand. These are all the steps. This isn't easy, guys. This is hard stuff that identifies the payer-specific requirements for appeal letters. You know, do you have one place where all of that goes? Take the opportunity to put that in here. Provide the scripts or content for communication to your physicians to facilitate the appeal letter. You know, because one of the things that a lot of appeals die on was because I don't know how to talk to the ER doc. Well, create the letter. Come up with some things together that says, look, this is what I need. This is what happened. Can you look at the account and see if it is appropriate to write the following? You know, we don't want to lead them down, but this is where compliance comes in. This is where HR comes in, okay? We want to make sure that all the options are consistently followed. We want to build trust in our system. We want the CFO, the CEO, coding, the departments all to trust the billing office, okay? And again, we want to make sure, does the policy show that we can identify if the letter was sent? Does it say include a copy of the letter in the patient chart? Or, how was it sent? Was it sent via paper? Just all the way down to those very little things. Hey, if this thing takes 20 pages to put together, and I got a really good comprehensive one, take the 20 pages. All right? So these are not quick fixes. This is also why this has to be cross-functional teams. Huge one is the charge modification within the billing system. It identifies the parameters around the physical modification of accounts due to missed or incorrect revenue. Do I allow people just to do things without authorization, or do I have to have authorization? It identifies the people and the documentation necessary to make the change. Everything needs to be in writing. Okay, does that mean that it can be done via email, that it can be done via a letter? Do we have a form? What do we use? It ensures that decisions are driven by departments or coding, not the business office. It ain't their job. We want to make sure that somebody outside the business office is directing the business office to do this. So it's hugely important. This is where you start getting trust, right? Because if the steps are continually followed, all of a sudden, the billing office gets their wish. They're not making the decisions. It's the department in coding. Now, CFO has to take a big swallow because it takes longer to do. And all of a sudden, maybe my AR grows. That's okay, but so does your cash, right? So this is why everyone gets involved in the forest and the trees. Okay? So we start talking next time around how to, kind of create a defensible pricing strategy, because again, this is the next level on our onion that we're trying to peel, right? So a lot of times we've got to go through, and now the defensible pricing is really going to be geared on some of the feedback from our business office. It's going to be done on how the fundamentals are followed in my charge master. So now we've got the charge master fundamentals. I've got my business office policies and procedures, because now I'm identifying accounts with lesser of logic, and I'm identifying things that may be at 100% pay. How do I then create a defensible pricing strategy which then allows me to talk intelligently to patients that I can defend? I feel confident in the fact that we're not trying to overcharge people, and God forbid we're undercharging.